Taking the program ahead, now let me call upon the Vice Chancellor of Patan Academy of Health Sciences, Dr. Rajesh Nath Gongal, for his keynote lecture. And his lecture will be on the topic 10 years, experience of developing community palliative care.
Good morning, Your Excellency, ladies and gentlemen. It's a great privilege to be standing here and making this presentation in this August gathering of people with great hearts trying to reduce suffering all around the world. Even as I make this presentation, I would like to emphasize that I'm presenting on behalf of a large number of people who have worked tirelessly over the years. And if we have achieved something worthwhile, be it known that this is the result of a collaborative effort of a lot of people in this room, outside this room, in the country, and outside the country. I feel very blessed to have witnessed the journey of palliative care in Nepal from virtually non-existent to the stage that we are in today. And I feel also very blessed to be a part of this great team. 2025 is a great year for us. We're celebrating 25 years of palliative care in Nepal. Yes, it was in 2000 when we started palliative care with 4 friends, 4 sponsors, and 4 breaths providing free service in a private hospital. And soon after that, Hospice Nepal was born. And in 2002, we moved to a 8-bedded unit in Gongal, which was built by our friends in CE Construction. And there was no turning back after that. So here we have been for the last 25 years. In 2005, we started the community-based service in and around Kathmandu Valley, going even up to far as the hills of Kathmandu. Also in 2005, we started the education and training. At the time when we started, palliative care, hospice was, even the medical fraternity did not know about this, so we had to do a lot of training. And we devised this 2 days training, and by now we have taken more than 2,500 healthcare professionals through this training. This training we have done all on a voluntary basis, without any funding from anywhere. The hospice where we are working is in a land that we had leased. Now we have been able to procure a land in Dhapakhel in Lalitpur, and we've started the building a 20-bedded unit with training centers, and this is what it's going to look like when it's complete. I must say that we still need to raise about half the $1 million that's required for the building. Over these 25 years, there's been a lot of growth in palliative care in the country, and I'm very, very happy about that. We heard about from the Green Pasture Hospital yesterday, and all the great work they're doing, being led by Amrita here, and the great work that the Sunita project has been doing. We've heard about that, and we'll hear more about that today. Bharatpur Cancer Hospital started palliative care in the year 2004. They have a very good unit, and they are doing inpatient service, outpatients, and also looking after patients in the community. In Beer Hospital NAMS, there's a very good oncology unit, and palliative care has been integrated for a very long time there. Bhaktapur Cancer Hospital, again, a very busy oncology unit. There's a very good palliative care unit led by Dr. Vikas Anand, who's done postgraduate from All India Institute. In the Nepal Cancer Hospital, which is also a very busy oncology unit, hospital, and they have a very good palliative care unit there as well. In Trivand TUTH, in the Institute of Medicine, Dr. Baidya has been providing palliative care for a very long time there. A new development in BPKIHS, Dr. Sonia has been leading palliative care. She's an oncologist there, and a new hospice building construction has started. So in KIST Medical College, Dr. Vishnu Paudel is also doing palliative care there. In Patan Hospital, we have a unit, a palliative care unit there, and Hospice Nepal, I've already talked to you about that. So a lot of development, a lot of things been happening in palliative care. When we started out palliative care, we hardly had any morphine. We only had a morphine injection, and it was very difficult to sort of manage patients. But we were able to import oral morphine from India in 2005, the long-acting, short-acting, and with a lot of effort from Dr. Vishnu Paudel, Dr. Pradeep, and we were able to start manufacturing morphine in Nepal. And now we have all the formularies. We have syrup morphine, we have long-acting, short-acting, and injection morphine. And morphine consumption has gone up quite considerably from 0.001 milligram per capita in 2002 to 0.8 milligram per capita in 2019. I think a very big improvement there, but not at par with the global consumption of about 6 milligram per capita. So a lot of work needs to be done there as well. In the education, as we said, in hospice, we are Patan, we had been doing this 2 days training for a long time. Recently, NSTC, the National Health Training Center, has taken up the training. Thanks to Dr. Vishnu Paudel for initiating that. There's a training in Veer Hospital NAMS where all the postgraduate residents have to go through this 2 days training, and similarly in TUTH and in Gandaki and in Green Pastures has also been doing training for health professionals around their area. The formal education we have started in Patan, the fellowship in palliative care, the 18 months fellowship. One of our graduates is here, and we have two fellows in the training at the moment. You'll hear from Dr. Rajkumar, who is our first graduate later on, about this fellowship program. So things are happening, In 2009, NAPCare was set up. Dr. Baidya was the founding president. Dr. Vishnu Paudel is the current president, spearheading the development of palliative care in Nepal. But as you see, most of the care, most of the services have been developed in the urban areas. And in 2014, we thought we should also start working in rural palliative care. And this has been a joint project between Patan Academy of Health Science and Hospice Nepal to try and develop a rural model. What can be the rural model of care in Nepal? And that's what we've been trying to work in the last 10 years. The rural population, although if you look at the census, it's now only 33% people live in rural municipalities. But this was the political decision, making rural municipalities into urban municipalities overnight. But the access is still very poor. People are very poor. And according to World Bank, 78% still live in the rural areas. So it doesn't need a lot of research to say that the majority of need for palliative care is in the rural areas. We started out in Makwanpur district. Makwanpur district, which is about a few hours drive from Kathmandu, but the terrain can be quite difficult, and it has all the sort of the terrains of the whole country. It represents the terrain of the whole country. So from 2014 to 2016, we trained 2 of our local healthcare workers, Mr. Chinya Lama and Kiweta Bista, for 3 months in Hospice Nepal. And we initially focused on cancer only, as has been the history of palliative care around the world. And we did a lot of orientation of the FCSVs, local leaders and teachers, and we focused in one municipality to see if this model actually worked. And while we were looking at patients with cancer, we also found many patients with non-malignant disease, but with sort of a suffering, a huge suffering there. So it's like this girl who was, a 13-year-old girl who was mentally ill, and the families tie her to this stone grinder so that she could not go out of the house. And when she came to the notice of our palliative care workers, they initiated a support mechanism She was sent to Hedora, nearby city, to have a treatment, and she's now back in the community, rehabilitated. So because of that, we did a need-based study in 2017 to look at what was the need of palliative care in rural areas using the SPIC tool. And what we found was that about 6% of the people in the rural areas had NCDs, and of which about 3% required palliative care. And the conditions, most of the conditions were respiratory diseases requiring palliative care, frailty, and other conditions. Cancer was also there, but the non-malignant disease took the most of the cases. We also did around that time, we also did a sort of qualitative study looking at what was the perception of the mid-level health workers, because we thought these were going to be the key personnels providing palliative care in rural areas. And several themes emerged from that study. They were very, they highlighted the suffering that was in the palliative care in the rural areas. People suffering because of the unmet needs, patients with life-threatening conditions. They also emphasized on the frustration and the helplessness that they felt because they had no training and they did not know how to deal with these conditions. In fact, one of the health workers said he could hear, a person in the neighborhood crying in pain, but he would sort of take a different route to his place of work because he didn't know actually what to do. And but they said that if they were trained, they would be willing to take on this palliative care in the rural areas. So we came to the conclusion that the only way we can provide palliative care in rural areas is a home-based care at their doorsteps, because you cannot have hospices in the rural areas, and even if we did, they would not come there. The patients would not come there. So we said the learning from that was that this must be a part of the national health system. You cannot run a parallel system. And we must utilize the primary health system that is already there. The primary health system in our country is great, and it's the primary health system that has actually the development that we have had and the improvement in the health indices has been the result of the investment in the primary health system. There must be a local ownership. This must be done by the local leaders, the local municipalities. It must be inexpensive to initiate the program, must be sustainable so that the recurring costs must be low, and we must empower the local health workers, must be rewarding to the healthcare workers, and must involve the local community and develop what we call a compassionate community. So we were trying to work in this way. So in 2019, we were ready to expand to other areas of Mokwanpur. And we met local leaders, convinced them the need of palliative care. Now we had stories to sell from our initial area of work. And we asked them to allocate budget for palliative care and include palliative care in their program. And they did this very willingly. And we also asked them to identify healthcare workers for this responsibility and send them for training. We also asked them to put budget for the training, and they would pay for the travel allowances and daily allowances of the health workers who comes for the training to Patan and hospice, and we would train them for free in our institution. So we developed a tripartite MOU within Patan of Academy Health Sciences, Hospice Nepal, and local municipality. So we were trying to build up this as a system of primary healthcare system. The FCSVs are a very important and integral part of the primary healthcare system. In Nepal, we have more than 50,000 female community health volunteers, and I call them the angels of health in Nepal. But they are also overburdened. They have a lot of work to do, and they could not prescribe medicines. So we felt that the FCSVs could be a very important link in identifying patients in the community and become an interface between the community and the health workers in the health post and the PSCs. But we felt that the mid-level health workers would be the key persons to deliver palliative care in the rural Nepal, and rural hospitals would support them. And we emphasized that this was a local ownership, that it is their program and not ours. So in April 2019, we did the first rural palliative care training. We translated our handbook to Nepali and did this training. I'll talk to you about a little bit about the trainings. This has evolved over the years, and as it stands, this is a 4 weeks training, 2 weeks of which are in the academy and Hospice Nepal, a lot of interactive lectures, but they also need to assess patients in the oncology and the medical wards and in hospice. We emphasize both cancer patients and non-cancer patients, but we also, the challenge for us was how to motivate these people who have worked in the health post and primary health centers, just prescribing medicines for patients. How do we get them to feel from the heart? And we use the principles of medical humanities. When we talk a lot about life and death, we ask them how do they want to die? And about life, about suffering, hope, using a lot of narratives from the local context. Physiotherapy, managing colostomies, and care of children and elderly are part of the training program. The 2 weeks, they need to go back to the area of work, and we have given them certain works that they need to do before they are certified. They need to orient local leaders. They need to orient local health workers working in their area of work. They need to orient the female community health volunteers in their area of work. They also need to assess and formulate management plan for at least 3 patients with palliative care need. And they also need to fill the patient details on an online platform, the ODK, which then comes directly to the server at Partner Academy of Health Sciences. So these was the sort of several trainings that we have done. We have done up to about 8 trainings now. And we would not only train them and let them go, but we would continue to do mentoring and supervision. Telementoring is very important. We do Zoom meeting from time to time. We do an annual review meeting in each district every year. We visit them from time to time. And I think it's the empowering of these local health workers are the most important thing. We would discourage doing telemedicine directly with the patients. We would do that only very occasionally, because these health workers who work there, they are the ones who need to take the credit, and we do not want to be the great doctors in the tertiary hospital providing the care. So a lot of telementoring, but only very few telemedicines. And Chinya Lama and Kiweda Bista, they are the anchor persons for the rural palliative care. We also make drugs available. We send them tramadols from Patan, and we make morphine available from hospice. If there are patients in the community who require morphine, we would register these patients in hospice as community patients, and we would provide morphine. There are always some relatives of the patient in Kathmandu, and through these relatives, we would send the morphine for a few weeks at a time to the villages. So in 2023, this was in the fiscal year 2023, more than 3,000 home visits were made by these health workers, and more than 3,000 telephone calls. I think telephone calls are very important as a supportive mechanism. When there's someone who will pick up your phone when you're in problem, that provides a lot of support for the people in the rural areas. Looking at both cancer and non-cancer patients, at the time we had trained 40 palliative care workers by 2023, and in fiscal year 23-24, the numbers more than 3,000 home visits in Makwanpur alone, some from Thading district, also in the local municipalities of Lalitpur, people were doing home visits, telephone supports, and also one district in Gandaki province from Magdi. These people from Magdi had heard about this training in Patan, and they approached us and said, please help us with this training, and they would like to start palliative care in our area. So we did that, and they're doing all the great work there as well. So almost 1,000 patients, more than 4,000 home visits, more than 3,000 telephone calls in that fiscal year. A few months ago, we also did a first community volunteers training to develop the compassionate community. I'm not saying that we initiated the volunteering in the rural areas. They're always there to help. The people in rural areas are more they're more helpful than what you would find in the urban areas. But we need to sort of empower them with some training and some skills. So this is a very early phase, and we are still trying to evaluate and trying to find the best way of doing this training so that this training can be done by the local health workers to the community. We have sent Chinia and Kiveta, our supervisors, to Kerala, to Pallium, India, to see the great work that's been done there in mobilizing the community. And we'll hear from Smriti here later on about the great work that's being done in Kerala. And I think a very important thing that happened a few months ago was this MOU with the Ministry of Health in Bagmati province. So we did a MOU between Patan Academy of Health Science and the Ministry of Health in Bagmati province. This is the Health Minister, Mr. Honorable Kiran Magar Thapa, in the signing program with the MOU at Patan Academy. And they have now designated budget for the training for palliative care. And before this, the local municipalities were bearing the training, the transportation allowance and the daily allowance of the healthcare workers. But now this is being managed by the provincial government, and they have promised that they would continue and increase the budget next year. So with that help, we did the training for health workers from Sinduli and Nuwakot and Rasua, and we aim to finish complete Bagmati province in the next 1.5 to 2 years. So by now we have trained about 190 rural palliative care workers. And this is in the first quarter of this year, fiscal year, more than 1,700 home visits, more than 2,000 telephone calls. These are just numbers. These are data. Data are important. Data are important to go to the government and tell them, look, the need is there. But the data do not tell the magnitude of the suffering of the patients in the rural areas. You know, this is a 34-year-old person who had a cervical spine injury and has become quadriplegic. And this patient is catheterized, and every few weeks the catheter gets blocked, and they would have to travel 10 kilometers to the health centers to change the catheter, and paying about 7,000 rupees each time. Now our healthcare worker now goes to the patient's home, and it's changed to silicone catheter, and now it can be changed every 3 months. And the wife has been taught to take the blocking, to manage the blocking of the catheters. And this is how the wife, every day moves the patient from the wheelchair to bed. And we cannot take all the suffering, but just being there. Of course, visiting them and being there, support for them, telephone calls, I think a very important lifeline for them. A 67-year-old lady from Mokwanpur again, from Garib municipality, had stroke, very poor financial status, with huge bed sores, foul smelling. People stopped visiting her. And when we came to know this health worker is now providing support, the bed sores are much better, the smell's gone, people are coming back. And it's a big support for the 39-year-old son who has been looking after her. Some semblance of dignity there. This is a 27-year-old young man from Manahari in Mokwanpur. He, from very young age, he refused to wear anything. And that was okay when you were a child. But later, this became a huge societal problem for the family and for the community around him. And he was being cared for by his elder sister, who later committed suicide. And the family has built a small house of blocks for him to stay there. And he was sent to what we call the Manav Seva Ashram, a rehab center, but he had to come back because he wouldn't eat anything there. So when he came to the notice about palliative care worker, we talked to psychiatrists in our hospital, and we have been providing medicines for him, and he's now much better. He's now wearing clothes, and with the support of the people there, he's being looked after in rehab center. So this, what we like to call the Makwanpur model, what has that shown? It has shown the need is there, and the need is urgent. People are literally rotting away, living very undignified life and dying undignified death. We've also shown that it can be done. It's not expensive to initiate the program. It's sustainable. The mid-level health workers probably should be the key players with the FCSB's support. Morphine availability alone is not an indicator of palliative care development, because for every one patient who needs morphine, there are 10 patients who don't. And non-malignant disease must be given equal emphasis in the development of palliative care. I think the very important development is the closing the referral loop. Before, the referral was always from rural to urban, and it's one-way referral. People get stuck there and they die there. Now, with the people in place in the rural areas, we can confidently refer back patients back to their home. We had a young girl, Bipana, who was about 21 years old, who had osteosarcoma, had amputation, and she came from Dhading. And she was living in a rental place here, and because she was in a lot of pain, we brought her to hospice, managed her pain, and we sent her back to Dhading. We called up our health workers in Dhading to say, look, this girl is coming back to you, look after her. And as she was being looked after there, she again developed severe vena cava syndrome. She came back to hospice, we treated her with steroids, she improved, and we sent her back there again. She had a little child who could not come to Kathmandu, and she was, in the last days, she was there in Dhading with her child, and she died peacefully there. So I think closing the referral loop is a very important part of the development in palliative care. There are a lot of challenges. There has been a lot of challenges. There will always be a lot of challenges. The policy, the strategy is still stuck there, and I'm sure this will pass soon. The health workers need more support from the local municipalities, the equipment, the medicines, a lot of challenges. But we need to do that, continue to do the work, and this will slowly get better. So in the last, I want to say, a lot has been achieved. Let us celebrate. A lot needs to be achieved. Let us going to provide that dignity, the quality in living, and dignity in dying should be a right of every human being across the world. Thank you so much. Thank you so much.
Thank you very much, Dr. Rajesh Nath Gongal, the Vice Chancellor, Parton Academy of Health Sciences. Definitely your presentation has left us with very few words, alarmed. We've seen, we know of the situation, but looking at the various examples that we have in our own society, it's alarming. And I think all of us here present, each one of us, we go back, I think, pledging to ourselves and to the society that we'll do something better. Thank you very much for your presentation, and we wish you all the best. Also, God's blessings in all of your endeavors that you're working for, and it's people like you and your team, the contributions that you make, that make our society definitely a better place to live in.